Thank you, Carlo. Good morning, everybody. Thank you all for inviting me to come here to this outstanding conference. It's a great honor for me to be here. And you asked me to speak about the clinical management of patients in POSEIDON Group 1 and 2. Okay, here my disclosures, and now let's start. It's now 40 years that we have experience with the ovarian stimulation in IVF. Stimulation in IVF was introduced with the goal to retrieve safely and, of course, several oocytes within a calculable time frame. And at this time, those treatments were carried out under the motto, under the only diagnosis, tubal damage, and under the motto, one fits all, and more the lot helps the lot. And mostly a fixed protocol was used with 225 up to 300 units per day, and after the introduction of the GnRH analogs, first the agonist long protocol and nowadays the antagonist protocol. But meanwhile, we have a lot of other indications under which IVF is carried out, and we have to thank Antonio Lamarca and Serge Stunkara, who raised our awareness on the basis of publications of Nelson and Yates that there are different individual type of reaction to ovarian stimulation, the normal response, the high response, and also women with a reduced response. And it was the merit of the Bologna criteria who tried to initiate a first definition. What does it mean, reduced response, poor response? But today, we have to divide this group here, first horizontally in so-called low or hyper response, women with a completely normal ovarian reserve, and the real poor response with reduced ovarian reserve. And we have to divide it also vertically, because by age, and if we are honest and consistent, and it was discussed also yesterday, we have to enlarge this line also for normal and high responder. Only from the genetic point of view, and it was discussed long time yesterday, we know that with increasing age, we need more and more oocytes in order to achieve at least one euploid embryo. And for this, we have to enlarge it. And also, when we look at this column, I think the distribution must be changed. We see in women with advanced age quite more often reduced response. Normal response is fewer, and hyper response in this group is very rare. But I was not invited to come here to give an update for the stimulation traffic light of Sesh and Tony. I was asked to speak about the clinical management of women in group 1 and 2. And I think it's not necessary to repeat all the criteria for these two groups. It was done already yesterday, and likewise, the possible causes for these pathologies. But these causes we have to take into account in our therapy planning in the clinical management. And please allow me first that I will tell you several information about the circumstances in our country, in Germany. And for this, I have two informations for you, a bad one and a good one. The bad one first. Germany is a so-called high-price country regarding the medical drugs and also gonadotropins. It's the most expensive in Europe and probably under the most expensive all over the world. And now the good one. The pen with a fixed combination of pholitropin and lutotropin alpha is at the same price as the pen with pholitropin alpha alone. And taking this in account, and also what one godfather of ovarian stimulation told us many years ago when this fixed combination came into the market, that whenever GnRH analogs are used in the context of ovarian stimulation, there, by definition, is an LH deficit. Here you see him several weeks ago when he was, in this year, once more invited in the famous library of Cerono in Rome, the place where 65 years ago he had to convince the old gray-hatted man of the directorial board to start with the collection, with the urine collection, in order to produce HMG. And if you look now at the actual clarification by the EMA that an LH deficit is not only expressed in the measuring of the LH level, there are also other situations with an LH deficit. You can understand that for a lot of my colleagues in Germany, the indication to give this fixed combination is fulfilled, and it is done. And for a lot of my colleagues, isn't it, Robert, this combination has become the gonadotropin of the first choice. And so, such a lecture in Germany, at this point, I could say now, thank you for attention, and stop my lecture because all is said. But I think you will not be satisfied. You will ask, and what to do if we don't dispose over such a fast lane as you have. And here we have to think back to our instruments in medicine. And the first, and for me most important step, is to do a good diagnostic. Then only with a good diagnostic you will be able to do a good treatment. And then we have to ask, which gonadotropin should we use? Which GnRH analog regimen? And are there adjuvant therapies which will help us in such a situation? Coming to the diagnostic, are there any signs that might raise suspicion of a low or hypo response? And indeed, we have to look during the first treatment cycle or at the end or after the first treatment cycle. During the first cycle, we see an inadequate response, a so-called hyperresponse to adapted FSH therapy. The patients had a normal initial follicular recruitment using the fixed starting dose, but between day 7 and day 10 of the cycle, each of them showed a plateau formation on follicular growth. That means no more increase in E2 level and no more increase in the follicular size, while continuing the same age-adapted adequate FSH dosage. And at the end, or even as a resume after the first cycle, we see a low follicle output rate and a low follicle to oocyte index. All was explained very well yesterday. We see that we needed a significant increase in the total FSH dosage and a significant increase in the days of stimulation. And so, in our clinical management, we have to ask ourselves what to do. Should we react during the current cycle, or will we do a treatment adaptation in the next cycle? But don't forget, the latter means you will have, with the first treatment cycle, a failure cycle. It's only a diagnostic cycle. And a failure cycle is, beside of the positive pregnancy test, a major reason for dropouts due to the psychological burden and to the financial burden for the couple. And this we have to take into account. Are there clinical signs that could indicate a hypo or low response in women with adequate ovarian reserve markers? And we know that the first pathophysiology mechanism for such a hyporesponse is the presence of genetic polymorphisms affecting the gonadotropins and their receptors. And in a lot of such cases, with normal ovarian reserve parameters and these genetic polymorphisms, a higher basal FSH and or basal LH level can be seen during our diagnostic step before the treatment. And genotype testing before ovarian stimulation may be clinically useful to identify those women who benefit from an increment of the FSH starting dose and LH supplementation. And it was our German who published 3 years ago that the genotype analysis can now be provided at the same cost of other commonly used analyses like AMH, antral follicle count, and so on. And it's clear if with such a diagnostic and a reaction before you start the first treatment cycle, if you can only avoid 10 to 20% of the failure cycles, it will always be cost-effective. Which gonadotropin should we use? Urinary or recombinant? FSH alone or supplementation with LH activity? And when should it be done? Here, the classical study of Anna Pia Ferraretti in women with hyperresponse during the first cycle. And when it was seen, she divided the patients in 3 study groups. First, increasing the FSH dose, and in the other 2 groups, supplementation of LH activity by the HCG in the HMG or by recombinant LH. And you see very, very well that this supplementation of LH activity provided sometimes really significantly more oocytes, and also the clinical output was different. What we see here are the results with the combination of urinary and recombinant FSH, and together with Robert, we did a study in 2012 with nearly 5,000 patients included, where we compared in women with reduced ovarian response the recombinant combination, the mixed combination, and HMG alone. And I have to tell you that in this great study with the combination of urinary and recombinant gonadotrophins, we had the worst results. When we will adapt our treatment in the following cycle, there it was Alessandro who gave us a very, very good scheme. But first we have to see that even the group of Brussels said that with the aim to retrieve more oocytes, the more potent GnRH, gonadotropin, meaning the recombinant human FSH, may be the gonadotropin of choice for Poseidon groups 1 and 2. And for younger women in this group, if we want only to increase the FSH dosage, we have to look, are there variants or not? And you see, if there are variants in the FSH receptor, then we have to increase in a greater extent as compared with the other cases. And if we consider adding LH in the 2-to-1 ratio, then we have to start from the first stimulation day, and especially in women who consumed more than 3,000 units in the previous cycle. In the Poseidon group 2, we have to use 300 IU daily. We have to consider in those women with advanced age and very reduced reaction, the duostim, and we know from a lot of studies that especially in the group of 35 to 39, 150 IU daily from recombinant LH from stimulation day 1 should be given in both agonist or antagonist regimen. And which GnRH analog regimen should we use? And here the situation is a little bit contradictory. Both long agonist and antagonist protocols may be used in Poseidon groups 1 and 2, as once more the group of Brussels told us. The long GnRH agonist regimen is associated with a significant higher oocyte yield compared with the short GnRH agonist regimen, which is already done all over the world. And if you look agonist long and antagonist regimen, there we have to say both can be recommended. And a great study recently from China, once more, in terms of clinical outcomes, early follicular phase, agonist long protocol was the most effective protocol for young, poor ovarian responders. However, there were no differences in clinical outcome among the protocols in older patients. But we have also publications saying in older patients take a mild GnRH agonist long protocol due to the better synchronization of the view of oocytes. It's somewhat contradictory. And lastly, we have to ask, are there adjuvant therapies which may help in this situation? And once more again, Alessandro published that with DHEA, we will receive a better clinical outcome due to the higher androgen levels in the ovary. And this is also an idea, should we do an LH priming before starting stimulation in those patients? Or should we do a general LH supplementation, as I told it in the beginning, for the situation in Germany, especially in women with advanced age? Growth hormone co-treatment could ameliorate the pregnancy outcome for women with poor ovarian response under the POSEIDON criteria who failed a previous IVF ICSI cycle. The double stimulation, we heard a lot about this yesterday, and when it should be used once more again, also in women with advanced age. And one positive effect is probably we can reduce the ratio of dropouts. PGT is for older patients the question. The progestin priming before ovarian stimulation did not show any good effect. And so let me conclude that the most important thing in this field is a very, very good diagnostic, mostly before we start the stimulation. And during the first cycle, we have to ask, is there a possibility to rescue the cycle in order to avoid a first failure cycle? We should use recombinant gonadotrophins, do a dose adaptation, and if we do an LH supplementation, then start at the first day of ovarian stimulation. Adjuvants could be double stimulation, but then antagonist cycle, freeze all, PGDA could be done, and in order to have a higher androgen level in the ovary for better maturation of the oocytes, we should think about adjuvant therapy to increase the androgen levels. Growth hormone may be helpful, and now I can say really thank you, molto obrigado.